So hi to everybody. Thank you very much for inviting me to have a lecture online in your conference. My name is Rudin Dome, Faculty of Medicine, University of Tirana. And my topic for today will be perioperative medicine and ERAS protocol. First of all, nothing to declare like conflict of interest. You know that ERAS protocol means enhanced recovery after surgery. This is a multimodal, multidisciplinary, let's say, care regarding to all the phases of the patient in order to optimize entire perioperative period. This program aims to reduce complications and can reduce the complications by 50% compared to conventional perioperative treatments, and there are several ERAS protocols regarding any kind of surgery. Let's have a look on perioperative fluid therapy and fasting during ERAS. So the key concept, as all the anesthesiologists know, are perioperative hemoglobin optimization, avoiding perioperative dehydration, optimizing intravascular volume, maintain mean arterial pressure over, let's say, 65 millimeter of mercury scale, and optimum of hematocrit, and of course using low dose vasopressors in order not to overfill the patient only with let's say only with liquid. So the key principles when I'm using or thinking about the fluid therapy are avoiding fluid shifts, individualizing the amount of fluid that are given to the patient, of course rapid normalization to enteral intake, to hydrate the patient, to avoid unnecessary bowl preparation, but taking in consideration some factors like the reduced preload when are using the positive pressure anesthesia, ventilation, sorry, the vasodilatation effect of drugs and anesthetics, the patient position, and this is a new concept that we can tolerate, let's say, can tolerate an urinary output till 0.3 ml per kilos in an hour for 2 to 4 hours without giving the patient additional fluids in order to, let's say, to avoid overfilling. Because, as you know, we can maintain the ERAS protocol, so the balance that ERAS protocol recommended to us from 0 to +1 liter in perioperative period for 70 kilos of person. But if we are going to overfill the patient, we are increasing risk of edematose, pulmonary edema, cerebral edema, ascites, postoperative ileus, and all the complications related to overfilling the patient, cardiac as well. But underfilling the patient is pretty the same, the high risk. So we can predispose the organism for ischemic damage, like brain ischemic damage, or like acute kidney injury, gut hypoperfusion, and so far. So ERAS protocol has a little bit, let's say, eradicate or mitigate all the physiologic stressors, giving us some logically measures to taken by. So meal by mouth, carbohydrate loading, bowl preparation only when necessary. If we are if we have a euvolemic patient, but the blood pressure is not raising as we perhaps want, so we have to use a low dose of vasopressors, and of course to maintain blood pressure, mean arterial pressure, euvolemia, to avoid bowel preparation, and to promote carbohydrate during 2 hours before. So this is a very interesting algorithm. If you had no heart failure, no gastric issues, no diabetics, so 3 carbohydrates drinks before the evening before and in the morning. But if are diabetics, only water, or diabetics with gastric issues, only 2 carbohydrates. So no diabetics with gastric issues, only 2 carbohydrate drinks the evening. Let's have a look, let's say, between ERAS and cardiac and thoracic surgery. So, ERAS protocols is a very wonderful paper published in JAMA Surgery. We can see that low preoperative serum albumin is a predictor for increased risk, correlating with length of time of ventilator, acute kidney injury, infections, and increased length stay in hospital. So, smoking cessation and alcohol abstinence for 1 month has associated with improved postoperative outcome after surgery. A carbohydrate drink, let's say, with 24 grams complex carbohydrate 2 hours before can reduce insulin resistance and can help us, so the physicians, in order to maintain a normal glycemic state during the surgery and in the recovery in or extubation in ICU. A hot topic in this phase is, of course, reducing the infections. So the recommended are to use chlorhexidine, to administer antibiotics 30 minutes till 60 minutes prior to the surgery, and to eradicate staphylococcus by using topical intranasal antimicrobial to eradicate staphylococcus colonization. One of the major problem in after cardiac surgery is bleeding. But if it's a bleeding patient, the patient is complicated. The dead chest are not early removed. The patient is not mobilized. So, in order to minimize all the complexity that is happen after increased bleeding, so we must minimize bleeding, and use of tranexamic acid. It's recommended in ERAS protocol in order to reduce the likelihood of bleeding, and of course avoiding hyperthermia during rewarming the patient, minimize conjunctive dysfunctions that is verified when we are going to overheat the patient. But it's not hyperthermia. It's not only hyperthermia to be avoided. It's hypothermia also to be avoided. And we recommend the prevention of hypothermia as well as hyperthermia, because hypothermia can induce bleeding, acidosis, hemodynamic derangements, and so far. Taking control of glycemia is one of the mainstay of this patient. So the glucose must have from 160 to 180 by using let's say insulin on pump, and multimodal analgesia. It's a very crucial point in reducing all the complexest complications that are following a not aggressively and correct treatment of acute pain. So it's encouraged epidural analgesia and the multimodal opiate sparing pain, let's say pain management, including non-steroid anti-inflammatory drugs, pregabalin or gabapentin, Dexmed, and so far. This is pretty the same with the thoracic surgery, but you know that during the thoracic surgery there are some points to be dealt with. For example, acutely aggressively treat treatment of acute pain. It's very important, because if the patient with pulmonary resection, for example, have pain, they cannot cough, they cannot maintain the airways and respiratory function, they cannot avoid hypoxemia and let's say atelectasis and all the complications related to the status of the patient, and of course to the kind of surgery. So avoiding overfilling or underfilling, avoiding hypothermia, treating good the let's say the pain, smoking cessation, minimally invasive surgery, iridescent removal, avoidance of urinary catheter, and ileal mobilization are, of course, the mainstay of ERAS protocol in this surgery. What about urology? There are very complex situations in urology, like, for example, radical cystectomy. So, as you know, preoperative counseling and education is very important in this patient in order to explain to the patient what is going with them after the surgery. But of course, preoperative medical optimization, avoiding bowel preparation, or encouraging giving them liquids, clear liquids before the surgery, and of course using multimodal analgesia treatment in order to minimize all the complications from acute pain, not corrected treatment. Thromboprophylaxis is also antibiotic prophylaxis with or without bowel and skin preparations, of course with skin preparation, but without bowel preparations. And of course, taking care about fluids, because radical cystectomy, for example, is a 6 hours of let's say approximately of duration in open surgery. So probably the physician is not aware about the amount of liquids of fluids that is given to the patient. So taking care about this, it's very important in order not to have such a huge positive balance. This is a very, very interesting paper in Hayes recovery after surgery protocols in patients undergoing radical cystectomy and ileal diversion. So there are 90 patients divided into categories: 45 ERAS and 45 non-ERAS. Normal diet before, night before, 300 grams of carbohydrates dinner before, clear liquids 2 hours before, and no bowl preparation in the ERAS group. ERAS group demonstrated shorter time to first flatus, shorter time to first stool, shorter time to normal diet, and reduced loss of length. And regarding let's say the complication, you may see that probably postoperative ileus is 14 patient ERAS, 20 patient non-ERAS. Nausea and vomiting, 7 patient instead of 11 patient, and you can see that eviscerating 2 in ERAS and 3 in non-ERAS. Postoperative ileus, I don't explain, Clostridium difficile enterocolitis, 3 patient ERAS, 5 patient non-ERAS, and so far. So using ERAS protocol, we can minimize the complication. Let's have a general look. So preoperative smoking cessation can reduce postoperative pulmonary complications. Perioperative nutritional therapy, older and because the patients are older and malnutrition. So we must take care about this. Avoiding bowel preparation, established a protocol regarding thromboembolic prophylaxis, preoperative fasting to promote or encourage giving clear fluids 2 hours before the surgery, antimicrobial agents like the second generation or beta-lactam or serotonin, and of course prevention of postoperative nausea and vomitus using antiemetics, acute hydration, and total intravenous anesthesia. In intraoperative and postoperative ERAS in urology, taking present that amount of fluids must be 1 to 3 ml per kilo an hour. Hypothermia prevention, early gastric tube removal remains controversial. Multimodal analgesia, epidural, systemic peripheral blocks, and avoiding postoperative ileus, of course, help us to early oral intake, if possible, with clear fluids, if possible, after, let's say, even some hours after the surgery, and of course, early mobilization and physiotherapy of the patient. What about ERAS and orthopedics? So total replacement therapy, total hip replacement. This may be young patient, but this may be older patient. This may be elective surgery, but this may be emergency surgery. So we have to take care of all of these aspects, and of course, pre-admissions counseling, and to explain to the patient what is going on with them. It's a crucial one. Regarding interoperative, we can before focused in anesthesia protocol, prevent hypothermia, fluid management, for example, should be individualized to the patient to maintain euvolemia. uh, Antibiotical prophylaxis has been to decide it, let's say, case by case. But of course, we tend that after the surgery to if we have to maintain, or we realized that we had maintained all the parameters as interpreted as normal as they were in perioperative, so we can encourage the patient after we treat the acute pain. We can encourage the patient to early mobilize and to be in normal in let's say in normal oral intake. What about major abdominal surgery? So major abdominal surgery, it's pretty the same like major urology and major orthopedic surgery, but there are some let's say some specifics, because you know that carbohydrate drinks can be taken properly, but are not taken after the surgery, or within the first out of surgery, because the possibility or the gut may be incompetent, so has no possibility to have a return function as well. But of course, they may have postoperative illness that is to be it's to be avoided. They may have postoperative nausea and vomiting. So ERAS protocol is especially in abdominal surgery, especially in, let's say, in surgery of uh, um, uh, for example, radical colonectomy and so far, or radical gastrectomy. So there are surgeries that may have a last-longing surgery, and of course much, less aggressive surgery can help us to have a normal patient in the postoperative in the postoperative period. But early oral lymphae, oral fluids as soon as the patient is lucid after surgery, early mobilization, multimodal opioid sparing, and folic catheter should be removed as soon as possible within, let's say, 24 hours before the surgery. So after the surgery. So in the recommendations of elective colorectal surgery of 2018, the patient should receive dedicated preoperative counseling routinely. Smoking should cease preoperative for at least 4 weeks. Impact of multimodal rehabilitation to increase functional capacity. Preoperatively, patient at risk of malnutrition should receive additional nutrition treatment for 7 to 10 days. A multimodal approach to postoperative nausea and vomiting should be considered in all the patient. Avoiding routine sedative medication, no routine bowl preparation, and chlorhexidine skin preparation. IV antibiotics one hour before, maintaining euvolemia and electrolytes, and encouraging fasting for solids, and giving 2 hours 2 hours before the surgery, clear liquids with carbohydrate loading. So these are beautiful places from Albania. You should visit Albania. Thank you very much, Teşekkür ederim, and Faleminderit for your invitation to be part and to have that lecture, this lecture in your conference. Thank you very much.